Assalamualaikum warahmatullahi wabarakatuh. Saya Nur Akilah binti Nawi, nombor matrik 9209251151360001 daripada kampus OUM Kota Baru, Kelantan. Untuk semester 8, saya telah praktikal Nbcp 2424 Clinical Practice Pre-Hospital Care and Ambulance Service di Hospital Setiu selama 10 hari. Pada hari ini, saya akan membentangkan tajuk case study saya untuk subjek Nbcp, iaitu case study yang bertajuk The Management of a Pre-Hospital Care Patient with Closed Fracture Mid-Shaft of Right Femur. Okey. Tajuk case study saya lah The Management of Pre-Hospital Care Patient with Closed Fracture Mid-Shaft of Right Femur. Untuk introduction, pre-hospital care and ambulance service is the provision of medical care and intervention to patient or victim at scenes during transfer or between hospital by trained and credentialed provider under the supervision of a medical advisor. It covers a wide range of medical illness from minor illness and injury to life-threatening condition. There is more trauma-related emergency, especially motor vehicle accidents, and a greater need for pre-hospital care service. The case study that I have chosen is about MVA case with femur fracture. Femur fracture are very common in the population under 25 years of age and in the population over 65 years. The incidence of femur fracture is about 1 in 1,000 patients a year. Patient with a fracture of the femur can lose 500 to 1,500 ml blood, and this loss may be greater if there is an injury of the main blood vessel. Therefore, more than 50 patients with femur fracture require blood transfusion, and this patient represent the case for intensive care unit ICU. The femur is the largest and strongest bone and has a good blood supply. Because of this and its protective surrounding muscle, the shaft require a large amount of force to fracture. Okay, presentation of the case, patient demographic data. This patient name Mr. F, age 22 years old, male, Malay, married, date of admission 23 of August 2021, time of admission 5 p.m. Okay, history of present illness. This MVA case is the ambulance call attended by PHC team Hospital Setiu and brought to emergency department Hospital Setiu. This case is a large motor vehicle accident versus MB versus car. Patient was motorbike rider wearing helmet and was found on the roadside near Kampung Permaisuri Setiu. Patient claimed that the car in front of him turned without signal and he hitting the right side of the car. Okay, initial assessment and management at scene when PHC attend this patient. Patient was assessed using AVPU method. Patient was responsive to pain stimuli. Patient sustained multiple abrasion wound over right elbow, right lower limb, and deformity over right femur. No LOC, no vomiting, no ENT bleed. Okay. Primary survey, danger. Patient transferred to the safe place. All staff wear PPE, face mask, shield, glove and gown. Response, patient was respond to the pain stimuli. Airway, open airway by jaw thrust maneuver. Look, maxillofacial injury, no foreign body seen, no secretion, no active bleeding from bilateral nostril and oral cavity seen. Listen, no stridor, gargling sound and no hoarseness of voice. Feel for airflow at the mouth and nose. Maintain cervical inline. Cervical spine was support using cervical collar. We use in the indication cervical collar for his patient was high impact injury and neurological deficit. SpO2 95 on nasal prone 4 liter per minute. Apply cervical collar, cervical collar inline. Breathing, inspection, no distended neck vein of neck, no wound at neck, symmetrical chest wall movement, no upper chest wound, no bruises, tachypneic respiration rate 28. Palpitation, no trachea deviation, no subcutaneous emphysema at the neck and chest, no chest wall tenderness, chest spring negative, and the percussion, no hyperresonant, no dullness. Auscultation, equal air entry, no reduced air entry, no muffled heart sound, and no crepitus valve. Okay, circulation. Being radial, posterior tibial artery, and dorsally pedis artery is good pulse volume. Capillary refill time is less than 2 seconds. No tachypneic, warm peripheries, and sensation intact. BP is 140 under 90, pulse rate 110 at scene. One large bore granula injected, both antecubital fossa. Run fluid castelloid 1 liter of sodium chloride. External bleeding, no massive bleeding seen. Blood taken for lab investigation, FBC, RP, BUS, BT, FBTT, INR, and water sign when admission at ED is 150 and 90, pulse rate 105, respiration rate 22, SpO2 99% on high flow mass, pain score 8/10, and temperature is 36.5. Abdomen inspection, no wound, no bruises, no hematoma, abdomen not distended, palpitation soft, no tender, no guarding, auscultation, bowel sounds normal. Pelvic, no wound and bruises, no deformity, pelvic spring negative. We check for disability and neurological status. GCS, Glasgow Coma Scale is full GCS, 15/15. Pupil reactive bilatery, no eye, no throat bleeding. Expose and environmental control. Exposing patient and warmer blanket apply to maintain of his body temperature to prevent patient from hypothermia. Lock roll, no cervical and spinal tenderness, no step deformity. Per rectum, no bone fragment, no height riding prostate, and a tone intact, no bleeding seen. Okay, we do secondary survey to the patient. Secondary survey, allergic, no history of allergic to medication or food. Medication, not taken any medication. Past medical illness, no past medical illness, no history of surgery. Last meal around 1 p.m. during lunch hour. Event related to injury, large MVA, motorbike versus car. Patient was 32 years old man, married and motorbike rider. Wearing helmet, speed more than 80 km per hour. Accident happened on his way to back home from work. The car suddenly made a U-turn and hit the motorbike from back. Patient was thrown away and fell on the right side of the road at Kampung Permaisuri, Setiu, Terengganu. Okay, head to toe examination. Head and face, no hematoma, no depressed skull, no maxillofacial deformity, no mobile facial bone. Cervical spine and neck, no wound, no bruises, no hematoma, no cervical spine tenderness, no step deformity. Ear, nose and throat, no recurrent eye, no Belter sign, no ENT bleed. For chest inspection, equal chest rise, no open chest wound, palpitation, no subcutaneous emphysema, chest spring negative. Percussion, resonance, no dullness. Auscultation, equal air entry, no muffled heart sound. Dual rhythm, no murmur. And for the abdomen, we check for inspection, palpitation, and auscultation. Everything is normal, no wound and bruises, no hematoma, no abdomen not distended during inspection. Palpitation soft, no tender, no guarding. Auscultation, bowel sound normal. And the perineum, no scrotal hematoma, no blood emitters, and an anatome intact. Upper limb, right upper limb, abrasion wound, bruises, no obvious deformity. For left upper limb, no wound, no bruises, no obvious deformity. For lower limb, right lower limb, no wound, swelling and deformity. Hair traction apply. For left lower limb, no abrasion wound, no obvious deformity. Rate of motion both limb was limited due to the pain. Okay, we go to the adjuncts to primary and secondary survey for this patient. For this patient, we do chest X-ray. The finding is normal, no hemothorax, no pneumothorax, no rib fracture. Pelvic X-ray also no fracture seen. And for right femur X-ray, we are finding close fracture mid shaft of right femur. No fracture seen at the distal and proximal femur. For the fast scan, everything is normal. No free fluid in hematorium, margin pouch, pericardium, splenoria, and bladder. For blood investigation, we take FBC to look for hemoglobin due to the bleeding. White blood cells are increased due to injury. Other results are normal. We took blood urea serum electrolyte views to identify any electrolyte imbalance, and all results are normal. Urea 5.2, sodium 140, potassium 4.0, chloride 100, and creatinine is 53. PT, APTT to identify blood clotting time, group and cross match to stand by for blood transfusion if needed. So the diagnosis for this patient is large MVA with close fracture, mid shaft right femur. The management to the patient, this patient is an ambulance call. So this case was attended by PHC team at scene, and this patient is brought to the hospital CTU and trash patient to the yellow zone at hospital CTU. When patient came to the hospital CTU, first we check for airway, maintain manual in the line stabilization, keep cervical collar. Breathing, keep on oxygen via high flow mask 10 liter to maintain the oxygen. Attach pulse oximeter to monitor oxygen saturation. And for the circulation, we take for vital sign monitoring every 15 minutes, blood pressure, pulse rate, respiratory rate, and oxygen saturation. Cardiac monitoring is attached to the patient, and intravenous drip 2.1 normal saline, 1 flask and 1 fistula funding given to the patient. Drug and management to the patient, IM-ATT 0.5 mg stat. This vaccine is given to provide protection against tetanus. IV morphine 2.5 mg stat and PRN. Total given 10 mg as narcotic analgesic for the management of pain. IV rozapine 2 gram stat, antibiotic used to prevent of bacterial infection. We also give this patient IV metronidazole 500 gram stat as a combination antibiotic to prevent bacterial infection. This patient also we dressing the abrasion wound on the right upper limb using saline and flavin to keep the wound clean and to avoid any infection. Apply femoral traction splint to right lower limb for immobilized and well-aligned fracture. Also examine for deformity, swelling, bleeding, discoloration, bone protrusion, and check for motor function and sensation. Capillary refill, distal color, movement, wound, and sensation need to be assessed also to the traumatic patient. Okay, definitive care for this patient. We refer this patient to orthopedic team and surgical team for further management. This patient was admitted to the orthopedic ward, planned for operation, intermedullary root insection. Post-operation is this patient we refer for rehabilitation and physiotherapy. Okay, the conclusion for this case is this clinical case study is about a Malay male, 22 years old, involved in MVA with motorcycle versus the car. This patient is motorbike rider. According to a witness, the car not given the signal and hit the motorcycle. The speed of the motorcycle is 80 km per hour and wearing helmet. The patient is alert and conscious, no ENT bleed, no vomiting at the scene, and complaint of pain on the right lower limb. Cervical collar and lower limb splinting was applied to the patient at the scene by PHC team. This patient is brought to ED Hospital Setiu by PHC team and triaged to yellow zone. According to the assessment of primary and secondary survey, there is no life-threatening condition and injuries found in this patient. From the investigation and X-ray, this patient has been diagnosed as closed fracture mid-shaft of right femur. Yearly treatments such as splinting applied, IV drip analgesic and medication given to the patient. This patient has been referred to orthopedic and surgical team for further management. In conclusion, femur fracture are very common injury related to emergency and trauma service. Any suspected of open fracture must be treated with antibiotic as soon as possible to reduce the risk of infection. For the time between initial emergency and surgery, lower limb splint or traction must be applied first to keep the broken bone aligned and maintain the length of leg. Trauma situation require provider to consider the immediate needs of the patient, and pre-hospital care service are the frontline medical provider, which is the one important thing in stabilization the patient of trauma like femur fracture. Okay, so in primary survey, patients are being assessed through sequence A, B, C, D, E of trauma care in identify the life-threatening condition. A healthcare provider, especially first responder who can assess, identify and treat a patient and preventing the trauma threat of death will be effective in reducing trauma-related morbidity and mortality. So that's all from me. Thank you.